Hello and welcome to the Vestibular Disorders Association's Making Vestibular Visible and another episode in the series of Meet the Experts. I'm Dr. Kathleen Stross, a vestibular physical therapist and volunteer with VITA, where I serve on the Medical and Scientific Advisory Board. Today, we'll be talking about the journey through the healthcare system for the person with dizziness, vertigo, and imbalance. And as this audience knows, finding the right treatment for these symptoms can be daunting. But as we will discuss today, the path to finding the right treatment begins with the diagnostic process. And in the world of dizziness, vertigo, and imbalance, this requires a team approach. Who's on that team and what does that look like for you, the patient? Stay tuned to find out. Returning to the studio today is Dr. Joel Goebel. He's the current chairman of VITA's Medical and Scientific Advisory Board and is the professor emeritus in the Department of Otolaryngology, Head and Neck Surgery at Washington University School of Medicine. Before retiring from clinical practice in June of 2020, he was the director of the Dizziness and Balance Center. He's published over 120 peer-reviewed and invited publications and continues his research today. His current research interests include projects to improve diagnosis and treatment of vestibular disorders. And one of the most exciting areas of research that will touch many in our audience is identifying early predictors of persistent postural perceptual dizziness. Welcome, Dr. Goebel.
Thank you. Thanks for having me back.
Absolutely. We're so happy to have you back. We had a great response to the first conversation we had on Meet the Expert. And today we're going to jump in to talk about something that I know is near and dear to your heart. And that's the multidisciplinary approach to treating and evaluating and diagnosing those in the on their vestibular journey. I know you have some thoughts on that. And you told me even as part of your position on the VITA Medical and Scientific Advisory Board, you're making this one of your top, objectives. Tell us about that.
Yeah, Kathleen. When Cynthia Ryan asked me perhaps to do this, I thought about it and I thought, well, what would I bring to the board? The board has already had some distinguished members on it and had done some really nice things. But I thought, well, maybe we can take this a couple of steps further. And one of those steps is to see how you can get the various specialties on the team to actually work together to the benefit of the patient. Every member of the team, represented by members on the board, for instance, bring a particular expertise. And you do the best when you work together, and then you also bring your particular expertise to the table. So that was the first. And I've had some expertise with this teaching in London and in England for the last 20 years. I don't know if you all recognize the term University of Leicester. It's above England by about an hour and a half. About 20 years ago, one of the physicians from there came and visited us at WashU and wanted to see how we ran our team and our clinic. They went other places in Canada and in Australia, went back and developed the first English-based, UK-based interdisciplinary balance clinic.
What does interdisciplinary mean?
Since dizziness and balance can come from so many different problems with the body, you need a variety of specialists to be able to manage that. So from a medical standpoint, or the medical diagnostic, the physician team, it was otolaryngology, and it was neurology, and it was psychiatry, and it was neuro-ophthalmology, and occasionally bringing in the cardiologist and the internist. From the diagnostic side, it was what they call the vestibular medicine scientists and also the audiologists. And then from the rehabilitation side, it was what they call the physios or the physical therapists. Okay, that's the team. And so I would go over to England every year for 20 years. I'm going back in the beginning of May to do this, or I'm sorry, in September to do the same thing. And I watched this process grow up. And their first thought was, well, we'll have all these specialists in the room together. Patient will come in and everybody will see the patient together. Well, the National Health Service wouldn't tolerate that.
No.
Because one, it was truly a waste of resources.
Sure.
Not every patient needed every one of those providers. So now it has morphed into a well-established team, all the team members are identified, the patient would enter the portal through the lead ENT physician of the team, which is Peter Ray. It might enter via any one of the neurology consultants. It might also enter via any one of the physios or PTs that send somebody into the medical lead just to try to find out what's wrong. Once that person is seen by the medical lead, then an entire series of tests and appointments are all set up for the second visit. So really, it's turned into a two-step process. First step was to get in and try to unravel what is wrong. Second step is to get the diagnostic test to refine that and to get the other members of the team on board to help treat it. So,
I'm a visual thinker, and I'm thinking about this team that everybody is, let's say, in a circle of all these different kinds of medical positions. Your specialties would be another word for disciplines, right? Different specialties. And they're holding hands in a circle looking inward because they're going to talk to each other, but they're also looking outward because a patient could enter the healthcare system through any one of them, actually, and bring them in and be their first point of contact. But then for the second point, you're saying that's when the team approach begins in a particular kind of diagnostic testing process. Is that the same for everyone or different?
No, it's different. No, it's different. And I know some centers, some balance centers, you make an appointment with them and they just test you and test you and test you. And then you see them and they've got all the tests. And to my mind, that's a waste of resources. I mean, not every person needs all these tests. And so it takes someone looking at the patient and trying to decide what they think is wrong. And then they make a decision, what test or tests do they think will help refine what they think is wrong or how bad it is. So that's the appropriate use of tests. And the teams can actually be virtual. They don't necessarily all have to be sitting in the same room at the same time. But when you talk about centers that have multidisciplinary teams, the members of those teams are identifiable. Okay. You could say, well, who's your neurologist?
Yes.
And who's your audiologist? And who's your physical therapist? There are names behind those titles that are involved in the care of the patient.
And why would it be important to name an individual? Because it's, I think what you're saying is that the care of the vestibular patient is specific to a certain person, because every neurologist doesn't have that interest or expertise, or every physio doesn't have that interest or expertise. Same with otolaryngology. It's a specific, a particular neurologist, a particular otologist, a particular physio that's on the vestibular team.
Absolutely. Absolutely. And
why does that matter?
Well, it matters because I think people who are on the team, first of all, they want to take care of the vestibular patient.
You have to want to.
You have to want to. You know, taking care of patients with dizziness and vertigo can be frustrating because the diagnosis is sometimes hard to get. And patients, I have quite a bit of discomfort and need. So it's a challenge. So first of all, they want to. And second of all, they bring to the table enough expertise and enough experience to lend something to the team. So if I have for instance, I have a physical therapist who's maybe been in practice 5 years, but has seen a handful of dizzy patients, and usually is in neuro rehab or orthopedics or any other of the subspecialties. That's not as useful as if I have a physical therapist with experience and training and postgraduate knowledge and training in vestibular rehab.
Not only not useful, might be harmful.
Yeah, well, absolutely. And same way with the neurologists. There are neurologists that are interested in dizzy patients and in migraine, vestibular migraine, and in the treatment of dizziness from progressive brain disease. That's one type of neurologist. And then there's some that aren't. So just because you contact a neurologist,
right,
and it doesn't mean that neurologist particularly is going to have the interest or the expertise at helping you. And it's the same way with the otolaryngologists. Some of the otolaryngologists, when they graduate, they've had some experience in their residency dealing with dizzy patients. Some have greater interest in it, some have lesser. And the ones that have greater experience, what they tend to do, they tend to go out and continue that as postgraduate CME. They go to courses.
Education, yep.
They educate themselves. And so that's the type of ENT that you're looking for.
I think that's important because I don't think the public always knows. They think, well, someone told me to go to a neurologist, so I'm just going to pick one. But I like that the internet allows a person to see what are the interest areas of a particular physician these days. You can go to the doctor's page on their hospital or the center in which they belong, or maybe their office, and they'll tell you what they like to do. A neurologist who likes to treat muscular dystrophy, above all else, is not necessarily the one for your headache. And in the vestibular realm, I think someone who has an interest, like you said, likes to see the dizzy patient, will put that on there, don't you think?
No, absolutely. And we just finished a survey of the American Neurotology Society fellows, and this is going to be presented in May at the spring meeting in Boston. And the question was, what is your comfort level with complex dizzy patient, and what is your willingness to see them? And I was pleasantly surprised that 123 respondents, which is about a quarter of the membership of ANS, but that's pretty good for a survey. If they're based in an academic setting, if they're mid-level, in other words, not fresh out of fellowship, but they're in their like 40s, 40, 50 range, so to speak, they see the most complex dizzy patients in their office, and they are the most comfortable with managing the complex dizzy patient. So that was very encouraging to me to see that my colleagues in ANS are actually willing to do this. Now, is every neurologist willing to do that? No. Are some heavily surgically oriented? Yes. So just like you said, Kathleen, we're in an age of transparency. So you can go onto anybody's website and just Google their name, and you can see where their interests lie. And if it says dizziness, imbalance, vertigo, you look at their publications and it's aimed in that direction. You look at their training and their fellowship. Yeah, you can figure that out. So no, not every ENT is cut out of the same cloth, not every neurologist. In the same way with audiologists and physical therapists. So when you build these teams, you want specific people in those teams, in those specialties, because they will then bring that wonderful level of expertise to your team for the dizzy patient.
Now, VITA does have some resources for people who want to know how to find a doctor who has specific vestibular interests. So I know that if you look at VITA resources, and maybe we'll put it in the comments, how to ask your physician these questions, how to find the right physician to do that. When it's funny with internet today, when you search a doctor's name, there are so many ads. You have to scroll all the way down through the sponsored ads of Dr. everything to really find the doctor's website. So don't give up. It's not going to be the first thing that shows up on the search engine. You've got to go all the way down and find, like it would be for you, your information and your publications probably came under Washington University School of Medicine or the name of the hospital in which you are affiliated, right?
That's correct. Yeah. That's right.
So just for you guys looking for that information, you do have to scroll down a little bit on the searches. But let's talk about this. Lead us through the optimal diagnosis and treatment pathway for the dizzy patient, and what happens when that approach isn't possible.
Right. Well, I go off the tenet or the assumption that the first thing you'd like to have is to know what's wrong with you. And that's a diagnosis. And the diagnosis is so critical because if you start treatment in all different directions without a diagnosis, you can be delayed in diagnosis. Perhaps those treatments work a little bit, but they're not optimal. So the first thing that I'd like to see is that a dizzy patient, as best as possible, gets a diagnosis as accurate as possible. And the challenge is who's going to give that to you. You go to your family doctor or your internist, and you talk about, oh, doctor, I'm dizzy. There's a few things they're really good at. There's a few things they will really help make a diagnosis. And these are medical conditions. Okay, these are problems with hypertension, high blood pressure or low blood pressure, thyroid disease, metabolic diseases, all sorts of things that affect the entire body and make people dizzy. And so that's a good expectation for what they can do for you. They can clip off things that are happening of a general medical nature. It's unrealistic to expect your general medical doctor or your internist to make a very specific vestibular disease diagnosis. I don't think that that's quite within their wheelhouse. I don't think that's in their bullseye. I have seen some internists, for instance, actually lay a patient back and diagnose BPV. They did it right. They had an interest. Okay, but would all your internists do that? Maybe not. So the expectation of your general medical physician is for general medical diseases that might make you dizzy.
So is it possible that that first doctor you see, that internist or GP, might say, I don't find anything wrong with you, so I'm going to refer you on?
Well, I think what they would say is, I don't find anything in my expertise wrong with you.
Okay.
So you don't want to ever leave a patient with the idea that they don't have anything wrong with them when they came in saying something's wrong with me. So I
That's
think,
sometimes what they hear. They
well,
hear that might not be said. Right.
that they hear that.
Mhm.
So yeah, then they would get referred on, and generally it would split into two different pathways. The
Okay.
internist would say, "Oh my gosh, I'm really concerned about what you're telling me about
Mm-hmm.
how you lost sight in one eye for
Mm,
an hour, or you couldn't move your hand, or your face drooped,
mm.
or something like that." That would imply neurologic disorder. That your dizziness is not just vertigo and dizziness, and it's going to, with medicine or rehab or maybe even surgery get better, but is the sign of something really, really wrong.
Mhm.
Okay, then you're there. The tendency would be, rightly so, to send you off to a neurologist to
Right.
figure that out. Okay, if it's recurrent vertigo, if it's recurrent dizziness with or without hearing loss, um, I think that gets referred to ENT more often than not.
Mhm.
And the
Mhm.
challenge becomes, oh, like I said before, which ENT is seeing it? Because not
Mm.
all ENTs are cut out alike. There's some very, very sharp ENTs that know their vestibular diseases. And the reason I say that is I taught at the academy for more than 20 years, a 10-minute exam of the dizzy patient course. And it was full. There were 100 to 200 people in that room every single year for 20 years. So I
Mm.
know there's a group of ENTs
Mhm.
that are very interested in making a good vestibular diagnosis.
Mhm.
So if it turns out to be BPPV or Meniere's disease or vestibular neuritis, even superior canal dehiscence, perilymphatic fistula, they would be quite good at that.
Mhm.
Okay? Um, there's a group of patients who have dizziness, like you said before, with PPPD, the sort of postural perceptual dizziness, have had it for a long time. They're a tough group. They're a tough group to see what was the original issue
Mhm.
and why did you develop this persistent dizziness
Mhm.
from that original issue. But that would probably still start with an ENT or with a neurologist. The psychiatrist, psychologist might get involved in this process, but to
Now tell
diagnose,
me why that is. Why would that person be important when we're trying to find a diagnosis?
well, there's an engine driving all maladaptation. There's something's
Mm.
driving the process. So I think the person with triple PD who had a vestibular neuritis that they didn't get over and have a terribly damaged ear is going to respond differently to the treatments than for a person to develop triple PD from migraine or triple PD from recalcitrant BPV, benign positional vertigo, or head trauma, or any other reason. So I think to label somebody as triple PD and not know what the inciting event was, I think is doing a disservice to the triple PD patient, because you're really going to handle them quite differently. The vestibular migraine patient who develops triple PD, that's not truly vestibular rehabilitation therapy of a unilateral deficit. They don't have a unilateral deficit. They have an inflamed, involved central vestibular system that keeps getting tweaked.
You use the word maladaptation. Tell us what that means and how that can be present more of a problem, not only to diagnosis, but then to therapy, and why you might engage some of the psychological or psychiatric.
Yeah. So whenever anybody has an injury of any kind that involves the brain or connections to the brain looks to fix it. It starts this pathway towards adaptation right away. And sometimes that pathway is really good. And some patients, just through normal activities of life and time, they adapt.
Mm-hmm.
And they go back more towards their normal state. Some patients, however, after an injury, they go down the pathway of adaptation, of recovery, and then they stall. And they just stop. And all of a sudden, the part of their brain that controls emotion, it's called the limbic system, becomes involved. And the limbic system says, what's wrong with me? I'm anxious.
Mm-hmm.
Why am I not getting over this? Why do I feel this way? Why do I feel my body rocking? Why do I feel visual motion so sensitive? So it's sort of a patient who started a pathway of recovery and then froze. And then at that level of freezing, then their emotional pathways start to kick in from the limbic system that says, gosh, I mean, what's wrong? And so triggering of anxiety and triggering of depression, it's very common. And
Yeah.
so, yeah, that's the problem.
I think, and I think for the person, for those listening, it's important to understand that if a psychiatrist or a psychologist is a part of your team and brought into the diagnostic process for you, not to think that people are saying there isn't a physiological problem and that it's all psychological, but that you're saying that it's important to understand the mental and adaptive responses that go on, not only in the search for a diagnosis, but then in the treatment of the symptoms that do engage just how you feel, your emotions, your anxiety, and your ability to adapt to a new situation.
No, absolutely. And that's why I said in the beginning, Kathleen, that if somebody has come to you and said, look, you had this event, and we think we know what the event was. It was a terrible bout of vestibular neuritis. It damaged your ear. And then your brain started to try to fix it, but it got to a point where it couldn't go any farther. And now you're sort of stuck in this do loop of feeling poorly, half the days of the month and don't want to move. That tells a patient, you have a problem. We know your problem. We know the initial event, and we understand this pathway where you've gone to a certain point to try to adapt and to recover, and you froze. So it says we believe you.
We believe you. You're not making it up. No. So you enter the healthcare system through any one of these people. You the initial assessment determines maybe a pathway of diagnostic tests that might include a variety of things. You said that's not the same for every person. Right. And then take us to the next step there. And you're saying that different professionals or different disciplines might be brought in to manage. Let's pick up there and continue through that process.
Right. If the diagnosis of your vestibular problem includes an active, ongoing process in the inner ear or the eighth nerve, then the treatment pathway is a medical and very rarely surgical, but it's a medical and a surgical issue to try to calm down the active process. In other words, if you have uncontrolled vestibular migraine and you're having active attacks, there's an issue to try to just calm the brain down. So medicines you might be given, exercise therapy to calm things down, but you just got to get the brain to calm down. If you have Meniere's disease comes in waves and attacks, and you have to stop those attacks or you have to mitigate them. You have to get the ear to calm down. Okay, so that usually takes a medical and again, rarely surgical. If you got a hole in your inner ear,
Mm-hmm.
superior canal dehiscence, where you're
Mm-hmm.
sensitive to sound and sound makes you dizzy, that needs to be addressed. At least you need to know
Mm-hmm.
that's what you have. And then you can choose whether or not you're going to have that hole patched. So that's a surgical intervention. So that's a group of people that have an ongoing, active medical problem causing their vertigo and their dizziness. There's a whole host, and probably the larger portion of people who had an event, and the event caused a certain amount of damage, and now you need help getting back into life. You need help. You need rehabilitative help. And that's the whole basis of vestibular rehabilitation therapy, VRT, is to try to get the brain to adapt and to get you back as much as possible so that you can move your head without your vision blurring or jiggling, and you can walk within and in different environments and feel that you're stable, ground stable under your feet.
It's an important designation that you make there because I think patients want to know, and it's very important that they know that they're either in a current disease process that's active or that it is in something that happened to them in the past that leaves them in a state of needing rehabilitation. And I think that is one of the most important reasons that a person needs to have a diagnosis to determine the appropriate treatment is there something we need to stop right now through an intervention or through medication to stop a process that's actively ongoing? Or is it a virus or a damage or a vascular event that is long gone and now you're safe, but you need to work on recovery, right? I mean, I think patients need to really understand that, and that helps them turn their fear into hope if once that they're either going to stabilize the process or abate the process from continuing to develop, or that they're going to move towards treatment because it's stabilized.
Right, right. And I think the key here is that when you enter the rehabilitative limb of this,
Yes,
you really need to be sure that there's not an active process.
absolutely.
You know,
That's important.
you don't want to. One of my teachers used to say, you don't want to turn your brain off. That okay, I'm going to do rehab, and not keep thinking all along you've got an active process. There's something that
Mhm.
hasn't been found out. There's something here that is the reason you're not getting better is that it's still going on.
Yes, that's important. So, if any of you are listening and you're actively participating in vestibular rehabilitation and you're not getting better, but you need to make sure that your therapist is not missing something, that you go back and circle back to make sure that there's no active process ongoing. Dr. Goebel, you and I both have experienced situations where skipping that process can be very detrimental to the patient and to miss something that is an active process
Yeah, I
ongoing in the
mean,
background.
yeah, life gets busy, life goes on. You get your appointments to do your therapy, and everybody just stops thinking about, wow, gosh, maybe there's something wrong here. Your antenna don't go up when you see that.
Do you have a particular story that you think might be one of the most common situations of something that could be missed or misunderstood or wrongly categorized?
Yeah, I've seen I've seen patients, um, elderly patients, with balance disorder, and they'd been in physical therapy for months. They came in wide based.
Walking with their feet wide apart?
Yes, they're wide. Their feet are wide apart to maintain their balance.
Mm-hmm.
They walked a little like Frankenstein.
Mm-hmm.
And the two other questions I asked the spouse is your spouse is the patient having problems with short-term memory? Oh yes, doctor.
Mm-hmm.
And is there any problem with controlling the bladder? Oh yes, doctor.
Mm-hmm.
That's normal pressure hydrocephalus.
Mm-hmm.
And that's very common. I'd see in the office that type of patient was under the care of in therapy for months, And if that patient would have been shunted when this first started and relieved, normal pressure hydrocephalus isn't really normal pressure. There's some pressure. It's just at the point when you do the spinal tap, it isn't high. But if they get shunted early in that process, Kathleen, that can be reversed. But if that process goes on for months and months and months of shuffling and memory loss and incontinence, it's irreversible. So there's a classic patient that is harmed by this delay in diagnosis. Okay, so and that's drastic. I mean, that's a drastic story.
But it's true. NPH, or normal pressure hydrocephalus, is always considered when you have a patient of a certain population presenting in a certain way. And so it's very, very important that if you're not getting better with rehab and you haven't really looked and turned over all the rocks to make sure it's everything, you go back to that doctor, and your therapist should always be talking to you about if you're not getting better, what it might be and what you need to do next.
I mean, one of the nice things,
because they could come in with BPPV and be appropriate for vestibular rehab and then have something else. So sometimes patients have two things, right? So, I mean, it has to be, this is where the interdisciplinary team that we're talking about not only directs someone for treatment, but then turns around and goes back to the team when the patient doesn't return to optimal functioning and optimal health. So sometimes it's a out and one direction and then back in. Would you agree with that?
Yeah, I think starting with a plan and a diagnosis that you feel is correct. So there's a medical diagnosis. You've gone to your physician, and here's what we're starting with. And then you go through the process. You go through the testing. You go through all the vestibular function tests and the X-rays, etc. You go through the rehab, and if something doesn't smell right as you go on, that's where the good interdisciplinary team talk to each other and say, hey, doc, you thought this was, perilymphatic fistula when in fact it was superior canal dehiscence. Okay, or you thought it was vestibular neuritis when in fact it was the first bout of multiple sclerosis. And we just doubled back. So everybody in the team keeps thinking, and keeps talking to each other. That's why I said in the beginning, it's not just a neurologist and an ENT and a physical therapist or anybody else. It's dedicated people who are willing to do this interaction for the good of the patient.
That's wonderful. There are balance centers throughout the country. How many do you think have a functioning multidisciplinary team approach for vestibular rehab in the U.S. or maybe in North America? How many?
Oh, I would say if you look in the academic medical centers, you're more likely to find them there. Dozens, I would say dozens. And they may function all a little differently. Like I said, some may be test first type, which I don't agree with, but that's the way they do it. Some may study the intake information of a patient and try to get more done on the first visit. Many are built in their teams to call together whatever specialists need on the second visit or what testing. So I think if you look in the academic world, in the academic centers, and that's what the ANS survey really pointed out, it was the academic physician that was more likely to see the complex dizzy patient and more likely to feel very comfortable managing them. Okay, so and you can ask the question, well, I don't live near an academic center. I'm way out. I'm hundreds of miles away from an academic center. Well, there's a couple of answers to that. First of all, if the problem is bad enough, make a trip.
Okay.
I mean it. Make a trip. Get somebody to drive you. Make sure all the information's in first so that they know who you are and what you're there for. Sometimes if you're going to drive 200, 300, 400 miles to do that, they can set up some of your testing.
Right.
If they just know what your complaints are, they'll try to get as much as they can get done with that. So that's one. The second is talking with your local providers, your local physicians, and your therapists, and to try to see whether or not there's a move afoot to coordinate a team. Some private practices do function as multidisciplinary teams, so they're not all in academic centers. So you have to dig a little bit to find out if that's happening. 3 is telehealth. Telehealth has really taught us something in the COVID era. Prior to COVID, there was very little truly productive telehealth. I mean, you'd pick up the phone and ask a patient, "How are you doing?" And it just wasn't well developed. You had no means to put it in the medical record, except I called the patient, they're doing fine. You had no way to put a note together. You even had no way to bill for that. You took time to do that. You couldn't bill for it. Well, and that's all changed. When COVID came along, a lot of health was telehealth. And what telehealth is allowing us to do is to form virtual teams.
Yes.
With people in different locations. I mean, it's a real entity. They have a neurologist in one city and perhaps an ENT in another, and have access to their brain power, knowledge. And we're even working on a project with one of the residents graduating from Wisconsin, University of Wisconsin, for a more accurate phone-based evaluation of your ocular motor system, including head impulse testing and even posture control. Your phone has great capacity. The camera's
Yes,
really
it
good.
does.
It's got a gyrometer in it, so you can actually tell sway. Right. So telehealth is the other way. The rate limiting step here is the desire to form these teams. And that's why I took the job in Vita and to try to spur on my colleagues in neurotology, working with David Z at Johns Hopkins to spur on the neurologists, working together with the audiologists and the physical therapists, just like yourself and some of the audiologists here on the board, to form these teams.
Yes.
And don't think and don't try to do it alone. Don't put yourself out as a one-stop, I can do it all. I would never promote myself as the provider of physical therapy. I don't provide physical therapy. I know the tenets. I know the science behind it. I've published in the physical therapy literature, including your own practice guideline on VRT. So I've done that, okay? But I wouldn't do it, okay? So that's not my wheelhouse. My wheelhouse is diagnosis, medical, and occasional surgical treatment. That's my wheelhouse, okay? Physical therapist, their wheelhouse is rehabilitation and getting you better from an injury, process in the brain, and getting you to get you back into life. That's what rehabilitation is. And the audiologist, in my mind, is the expert at the vestibular function tests and just telling us, okay, we want to know as precise as possible what's wrong with your ear, what's wrong with your brain, what's wrong with your ocular motor system. And that's where the audiologist has the greatest expertise. And they come in and say, okay, well, we feel this is the damage that we see. Now, when you take that team together, that's a team. Right? And nobody reaches over and said, well, I can do it all. Nobody.
Right. That's important. And I really, really appreciate you bringing this information to people, and that when the optimal approach isn't possible, or if you're in your journey to recovery and you haven't yet experienced a multidisciplinary team and you're still suffering, it's not too late. Take Dr. Goebel's recommendation, find a center or an academic hospital system that has a multidisciplinary approach, and perhaps make it at the top of your list this year to get a multidisciplinary vestibular diagnostic approach. Perhaps somebody's missing something. And so if you're continuing to suffer, we encourage you to go back and start again to receive the accurate diagnosis that would lead to the most efficacious therapy and treatment. It may not be vestibular rehab therapy. It might be that you're needing something else. What is, these are all really, really exciting things to get the doctors motivated to make and create the teams, to get the institutions to designate funds to create these teams, and the rise of telehealth. I really find that very, very promising, to assemble teams that aren't limited by geography. And this is part of VITA's mission to reduce diagnostic times and improve treatment outcomes. And Dr. Goebel, I think you've given us a lot of good information about how healthcare providers are working towards this and joining VITA's mission. What are the other things you want to make sure you share with our audience today? I'm going to give you a 1-minute wrap up to wrap up this multidisciplinary conversation.
Yeah. Be patient with your providers. This is a complex process. And so I think to have a realistic level of expectation of your providers is good. Not expecting of your internist something they really shouldn't be doing, or that they can't do or don't want to do. So be patient with your providers. And the second is keep asking. Keep asking. If things aren't going the way that you'd like them, just keep asking your physicians and your therapists, is there something else we should be doing? Not doubting them, but just it's your body, and it's your life that's being impacted by this. So just be willing to ask questions. And the third is, like we talked about, is look for those centers. They are there. And I promise you, I've been working hard with my colleagues to make their practices and their willingness to take care of dizzy patients much more visible to you. Much more
Very
visible.
good. Excellent. Well, remember, the views and opinions expressed are not necessarily the views or opinions of the Vestibular Disorders Association, but they constitute the views and opinions of our guest, and they do not constitute medical diagnosis or care. As always, consult with your healthcare professional before starting or modifying your treatment plan. Dr. Goebel, it's a pleasure to have you on Ask the Experts again. I look forward to our next segment. You're going to organize and bring us some more topics and some more guests for this series, and I'm looking forward to that. And for those watching on replay or listening on the podcast, we welcome and appreciate your comments and suggestions, and we direct you to the Vestibular Disorders Association website at vestibular.org, where you can find more information like this and access to our referral network, where you can find a vestibular healthcare professional ready, eager, and wanting to take care of you. Thank you so much. And until next time, we'll see you on Making Vestibular Visible. So long.